Hi, my name is Dr. Simon Moore from the Review Course in Family Medicine and Vital FM Update. This is CFP Distilled, where every month we take the most clinically relevant articles from the CFP Journal and distill them down into an easy and bite-sized, memorable format. So, what are the articles that we need to know from the September 2021 CFP Distilled? Number 1, SGLT2 inhibitors, not just a diabetes drug. Number 2, testicular torsion in kids. And number 3, asthma, COPD, where do they overlap? Let's find out. So let's talk about the SGLT2 inhibitors. They're not just a diabetes drug anymore. There's cardiorenal protection for people with diabetes, and now the Canadian Cardiovascular Society guidelines say that everybody who has heart failure that's symptomatic with reduced ejection fraction should be on an SGLT2 inhibitor. So why is that? Well, here's the number needed to treat. If you have 100 patients and you put them on an SGLT2 inhibitor and follow them for a year and a half, 7 of them are going to say, I've had a better quality of life. 4 of them will avoid hospitalization, and you will save 2 lives, 2 fewer people will die. So now that we're going to be starting SGLT2 inhibitors on more patients at the cost of about $500 a year, what should we be telling our patients about this? There's 3 S's to know when you start an SGLT2 inhibitor. Number 1 is sugar, number 2 is sick day, and number 3 is it slows the kidneys. So sugar in your pee. This is how it actually works. It reduces your sugar in your blood by helping you pee it out. So if you're peeing out sugar, your sugar is going to be a very attractive place for yeast and bacteria to grow, and that's why sugar in your pee can increase the rates of urinary tract infections, balanitis, and yeast infections. So that's the first thing to warn your patients about. The second thing to warn your patients about is sick day management. Stop the SGLT2 when you're sick. If you become acutely ill or dehydrated, you want to stop the SGLT2 inhibitor, and you want to make sure you give written instructions to your patients so that they're aware of this need. And the third one, for patients who are on an SGLT2 inhibitor and they're just starting out, you might notice that it slows the kidneys. There might be a drop in the GFR. It's short, it's transient, it's usually about 4, and in fact, you don't even need to do anything about it. It's totally reasonable to just observe. Unless it drops more than 30, that's when you should act. So that's why SGLT2 inhibitors are being used for patients with heart failure, and 3 S's to remember when you start a patient on an SGLT2 inhibitor. Another very helpful article from the September 2021 CFP Journal is about testicular torsion. Now, a young lad comes into your clinic or emergency department, they've got scrotal pain, or maybe they've even got just abdominal pain. Do they have a torsion? Do they not? And you need to know this because there's major implications. In fact, this would be a great SAM question. What are 3 things that can happen if you miss a testicular torsion? So the answer from the article, number 1, reduced endocrine function. Number 2, infertility, and number 3, loss of the testicle. So how do we pick this up? How do we make it easy? Well, this article talks about the TWIST score, which is a fantastic tool you can use at the bedside to find out, does this patient have a torsion? Do they need further investigation, or do they not? Because a score of 0 essentially rules out a torsion, and it's been validated in kids. One final article from the September 2021 CFP Journal. It's about asthma, COPD, plus there's a third lung condition that looks like both of these that we need to know about in primary care. Now, we need to be able to distinguish between asthma and COPD, and there's long lists of criteria that help us point towards one or the other. One point that you may not have known is patients who have COPD usually have a history of smoking exposure, or instead of smoking, they might have been exposed occupationally to biomass fuels. So make sure you're taking a great occupational history. The other clinical pearl from this article you need to know about is this. Patients with newly diagnosed COPD need to have an alpha-1 antitrypsin test because we underdiagnose that condition. So what is this third condition we need to know about? It's called the Asthma-COPD Overlap. It was proposed by the authors of the COPD Gold Guidelines and the China Asthma Guidelines, and they said there's a new condition in which it's not really easy to tell these two apart. So why is it important to know the difference between these and how to treat them? It's because treatment is different. Major changes in the 2021 guidelines show us that we need to be giving inhaled corticosteroids to our patients with asthma first line, not just a bronchodilator. So patients with asthma, patients with ACO need to get inhaled corticosteroids, but not all COPDers need that. So one final quiz question about this. Which patients with COPD benefit most from inhaled corticosteroids? These are the folks with a high level of blood eosinophil level counts, and that's above 300, or patients with frequent or severe exacerbations. Those are the COPDers who are going to benefit most from an inhaled corticosteroid. When it comes to asthma and ACO, however, make sure all those patients are on an ICS first line. So that's it for the September 2021 CFP Distilled. Make sure if you're studying for the CCFP exam, check out the reviewcourse.com. We've got free exam tips, tricks, and strategies to help you succeed. Till next time, I'm Dr. Simon Moore. Take care.